Co-chair Professor Dr. Nivethitha is a speaker. Moving to the next session, we have Dr. Nivethitha to talk on atypical diabetes. Nivethitha is a concerned endocrinologist from Madurai. She is practicing at Anya Endocrine Diabetes Center. She did her DM from Amrita Institute of Medical Sciences and she is a gold medalist in DM endocrinology. Over to the speaker.
So, very good evening to everyone here. And first of all, I would like to thank Dr. Kumaravel sir and the receptor team for giving me this opportunity to share my ideas. So, the topic for today is atypical diabetes. What have we learned so far? So, this is something like which we have come across recently, and the classical teaching for diabetes. So, we all know, like we have read about type 1 and type 2 diabetes, and it's juvenile onset or adult onset, insulin dependent or insulin non-dependent. Actually, that is becoming so absolute in the era of precision medicine. So, atypical diabetes is something when a patient with diabetes presents with manifestations that overlaps with both types of diabetes. So, we don't know like how to categorize them actually. So, they have either non-type 1 or not type 2 diabetes. The definition actually, it sounds so simple, but in reality, we don't face this actually. It's so challenging because it's not straightforward, and most of the patients with atypical diabetes may have some clues in their clinical presentation. So, but when those presentations become apparent, it's actually a very long duration, so we tend to miss the critical period, like what type of diabetes they have. So, we have to have a higher degree of suspicion in diagnosing them. So this is how the history of classification of diabetes started, like as long as early as 1936, when they started to work on insulin sensitivity and beta cell function. So Harold Himsworth in 1936 gave some basic data, and by 1950, R.D. Lawrence is someone who actually diagnosed that there are two types of diabetes, and by 1955, the term type 1 and type 2 is coined by Dr. Philip. So Philip was from Jamaica, and even during those days, he had found out that there is a rare variety of diabetes in young patients who have insulin resistance. So he termed it as type J diabetes, that is J stood for Jamaica because he was from Jamaica. So now, this is the classical diabetes mellitus triad, the pathogenesis actually, which comes into three main types: insulin autoimmunity, insulin secretion, and insulin sensitivity. So if we see here, insulin secretion, insulin sensitivity, and insulin autoimmunity. Normal, so patients who have a normal glycemic mechanism, they have a very good insulin secretion and they have a very good insulin sensitivity. And as classically this actually when deteriorates, we have impaired fasting glucose where the insulin secretion and the insulin sensitivity like subsequently it tend to reduce, and then we have the type 2 diabetes where there is a reduction in secretion and the reduction in the sensitivity. And we have the other one, type 1 diabetes. The sensitivity is actually good. We don't have secretion. The autoimmunity is very high. So this is how the classical teaching is type 1 and type 2. And where does this atypical diabetes falls into this graph is like what we are going to see. So WHO classification of diabetes is type 1 and type 2. So we have hybrid forms of diabetes will be going in detail, and other specific types: monogenic diabetes, disease of exocrine pancreas, endocrine disorders, drug-induced, chemical-induced, infection-related, and uncommon immune-mediated diabetes, and syndrome associated, and also GDM and diabetes in pregnancy. So with this, I'll have some case scenarios, like actually presenting some of the most important atypical diabetes and how to approach them in our day-to-day clinical cases. So coming to the first case scenario, so this is a 35-year-old female. She just has fatigability and giddiness with some genital candidiasis. So any person with such symptoms, they tend to check the sugars, and her fasting was 174, postprandial was 267, and HbA1c 8.4. So on examination, her BMI is kind of normal and she is not obese. General and systemic examination is normal. So she was actually advised with lifestyle modification and just vildagliptin and metformin. And the follow-up, she was actually doing well. For the first 1 year, HbA1c was somewhere around less than 7. So what happens after 1 year? Suddenly, after a year, in a period of 2 months, she deteriorates. So she has excessive thirst and increased frequency of micturition, increased appetite, but she's actually compliant with medicines. It's not like she has missed the medicine, and at fasting shoots up to 320, postprandial becomes 400, HbA1c is 11.2, urine ketones is positive but ABG is normal because she is presented early. So this is how she presents an antibody. So now because a 35-year-old female who was actually initially doing well now presenting with ketosis, GAD antibody was done which was actually positive and IA2 antibody is negative. So she was managed with basal bolus insulin regimen and now she was actually put on basal bolus regimen and discharged. So what is this actually? So LADA, long-acting late onset adult diabetes in late onset autoimmune diabetes in adult. The terminology is changed, which shall be coming into later. So this is the criteria for LADA. Age, the patient must be over 30 years of old at the time of diagnosis and the patient has to have antibodies like it can be either GAD or IA2 and the patient will be classically insulin dependent at least in the first 6 months of their diagnosis. So that's very, very important because it's a very slow process. It's not like a type 1 where suddenly they actually go in for deterioration. And other criteria, they might have autoimmunity and it has a lower homeostatic model compared to people with type 2 diabetes mellitus. So if we see here, LADA is somewhere which doesn't actually come into any of these things. So the patient might have insulin sensitivity or not and either autoimmunity will be there and insulin secretion will be less. So this depends upon like how they are presenting and how is their autoimmunity profile. And now we are going to the case 2. We have a 40-year-old male, so who's like been completely normal, but suddenly presents with 2 weeks of catabolic symptoms of polyuria, polydipsia, weight loss, and vomiting. So he cold, hypotensive, and strikingly tachypneic. And these are the values. His blood sugars are very high, 456. HbA1c is also high, and the severe acidosis and the C-peptide because he is a 40-year-old male with C-peptide which is actually suppressed. And now what is the diagnosis? Like initially we thought he might be having a LADA which we had seen before, a 40-year-old male. So the management was done like as a DKA and he was put on basal bolus insulin. So this is how it was treated. And early onset diabetes mellitus with severe DKA, maybe LADA. So this is what actually was kept in mind. But in the follow-up, so when we suspect, like when a patient is having a DKA, we see the antibodies was negative. Surprisingly, the C-peptide levels actually got up. Fasting and postprandial C-peptide was normal, which was actually suppressed previously. And he was requiring only OAD, was completely off insulin. So now, this is what we call it as ketosis-prone diabetes, another word is flatbush diabetes, where patients have severe beta cell dysfunction with a variable clinical course. They present with DKA or unprovoked ketosis. It's actually common in black population, but we also see quite a few of KPDs in our clinical cases, and mostly it will be a middle-aged male, not overweight, with shorter duration of symptoms, and patient usually becomes insulin independent in a shorter period of time. And diagnosis actually has to be made after 3 to 4 weeks of diagnosis. So now, if we see here, there are 4 types of KPD. One is type 1A, 1B, 2A and 2B. We actually take the 2 important things, autoimmunity and beta cell function. So A plus B minus means it's positive autoantibodies and no evidence of beta cell function. A minus B minus is no antibodies, no evidence of beta cell function. And 2A, A plus B plus patient has antibodies and evidence of beta cell function, and 2B is no antibodies and evidence of beta cell function. That is the most common subgroup, but the patient actually had A minus B minus, that is he didn't have antibodies and also he didn't have any beta cell dysfunction because he actually recovered later. So this is how this KPD can present like in anywhere in this chart. Actually patient might have autoantibodies and in beta cell dysfunction. So the patient, our patient is like somewhere here, that is A minus B minus, he doesn't have antibodies and he doesn't have beta cell function, he recovered actually. So these are the hybrid forms of diabetes in the WHO classification. So they are like strikingly contrasting in each other. So one type, that is the LADA, which the terminology is changed. Slowly evolving immune-mediated diabetes of adults, where patients present with a milder form of diabetes then go for DKA and they require insulin. And KPD, depending upon their subtypes, they present with a severe manifestation, that is DKA, and progressively as time goes by, they might present like anything. So these are the hybrid forms of diabetes which we have to keep it in mind. And now moving on to the C-peptide target, like which I want to focus the most important thing. Never ever interpret a C-peptide when the sugars are very very high, because of the high sugars, patient might be in lipotoxicity, which is going to suppress their beta cell function. So beta cell function, when it is deteriorated, C-peptide is also going to get suppressed. So once the patient recovers out of the DKA, kindly we can interpret a fasting C-peptide and a stimulated or postprandial C-peptide. So we have the cutoff here, like our units actually comes with nanogram per ml. And C-peptide is very much important because type 1, yeah, we can manifest say type 1. And what happens is, when we have a patient whom we manifest, like we diagnose as type 1 diabetes, for more than 3 to 5 years post-diagnosis, if their fasting C-peptide becomes more than 0.08 and the postprandial becomes 0.2, actually, we can actually categorize them into type 2 or MODY. So this is one important thing, like by which we can categorize. But C-peptide still, the assays are subjected to many errors. So that is one thing. And now coming to case 3. We have a 17-year-old female with no past medical history and she's completely normal. And since she had irregular cycles, the TSH screening was done in a fasting state. That incidentally picked up a fasting plasma glucose of 156. Otherwise, she's completely normal. Her BMI is like a kind of normal. She's only 20th percentile for age and sex. And the fasting is 156, postprandial is 215, and HbA1c 7.5, urine has glycosuria, and rest of the examination is normal. So with this, we actually say like she might be having type 2 diabetes on the end, and then we do an antibodies screening, which is normal, and the C-peptide is also normal. It means she has a good insulin secretory capacity. Fasting C-peptide is normal, even the postprandial is normal. But what is actually, which hinted the diagnosis to go further was this family history. So this is our index patient who has had diabetes with 18 years, and she also has a sister who had diabetes at the same 18 years and she was branded as type 2. And if we look here, her mother has diabetes at an younger age and her grandfather has diabetes, and the previous generation, they are not very sure, but this is a 3-generational pedigree chart, like where everyone has diabetes, especially the first degree relative has diabetes in a younger age group. So now, based on this, actually, we do a genetic testing, that is gene sequencing, which picks out that she has MODY1 with HNF4A gene mutation. So now, how do we actually clinically suggest that the patient might be having MODY is having diabetes in at the age of less than 30 years, and diabetes diagnosed in less than 45 years without any obesity or insulin resistance or metabolic syndrome, because we have seen a lot of cases these days, and diabetes diagnosed in less than 45 years in a family history spanning across more than 2 generations. In the absence of DKA, no autoantibodies, and C-peptide has to be normal. So these are the criteria, and we have other additional specific features, and they might be having glycosuria even at a normal levels of glucose, blood glucose, and marked sensitive to sulfonylureas, and extra pancreatic features. So this patient, so MODY is somewhere here in the chart. The patient has a less insulin secretion and less insulin sensitivity. Mostly the autoimmunity is not going to be here. So this is where the MODY comes. And now, as this patient is having MODY1 HNF4A, she has a mild increased fasting and postprandial plasma glucose. And why MODY classification is important? Because not to push them into a diagnosis of type 1 and unnecessarily giving them insulin. But another thing is they have a very excellent sensitivity to sulfonylureas, especially MODY1 and MODY3, 0.5 milligram of glimepiride or 30 milligram of glyphosate, they do excellently very well, like MODY1 and MODY3. So that is why we need these kind of sequencing. Though the affordability, like we have been always discussed about, is the problem, but still it makes a big difference in their quality of life. And other important things, like why we have to screen for MODY, because they have other important complications like pancreatic agenesis and other urinary tract abnormalities. Especially MODY5 patient will be having multicystic kidney disease, and we have almost 14 types of MODY, at least now categorized in so many MODYs without gene sequencing. So that is very important. And now another paradigm which is changing is, classically we have been taught like we need 3-generational history for MODY, but now 50% of the patients is having de novo spontaneous mutation. So any young patient, always keep the diagnosis of MODY in the background. And now coming to the case 4. So he is a 20-year-old male. So this is a case like which I've come across during my PG period, and he was actually diagnosed to have type 1 diabetes mellitus from 7 years of age, and now coming with polyuria, recurrent UTI, visual disturbances, and poorly developed secondary sexual characters. So what is our general opinion about this patient? A type 1 diabetes for 13 years with all these symptoms. We will tell them that they have to control their sugars because they might be having some uncontrolled sugars, but on the contrary, HbA1c 7.5 in an average control. So what is the missing link here? Like what are we missing here in this patient? One thing is this polyuria, recurrent UTI, visual disturbance, and poorly secondary sexual characters. Like as we evaluated him further, one thing which picked important was sodium was 149 on the higher side and creatinine was high. And the visual disturbances like fundus examination has not been checked, and once we addressed him for ophthalmic examination, he didn't have retinopathy, he had optic atrophy. So importance of eye examination in a young diabetes patient, optic atrophy, diabetes, when it comes, the first diagnosis which should come into our mind is Wolfram syndrome, which I'll be discussing about, and USG had moderate HUN and a severe post-water residual urine. Urological examination, he has neurogenic bladder and sensory neural deafness, and water deprivation test confirm diabetes insipidus. So this is a Digmore syndrome, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. So he has Wolfram syndrome, and this is the criteria. So major criteria is diabetes mellitus and optic atrophy of less than 16 years, because we don't know how many of our type 1 patients still have Wolfram syndrome. So ophthalmic examination is something which has to be highlighted, and minor criteria is diabetes insipidus, diabetes mellitus like more than 16 years, optic atrophy more than 16 years, deafness, neurological signs, renal tract abnormalities, and mutation. So minimum required, we need 2 major criteria or 1 major plus 2 minor criteria, and other features they might have hypogonadism and no antibodies, cataracts might be there, gastrointestinal disorders, and psychiatric disorder. So this was a patient with Wolfram syndrome, and I'll just proceed with the next case 5. And so this is something which is rare, but still we have to keep it in mind considering the seriousness of the case. So this has been seen by almost all our seniors and juniors in the past 15 years in my college, because he has been following up 9 years and now he's almost 24 years. So 9 years old male, first comes with short stature, workup normal, termed as idiopathic short stature. 16 years he comes with diabetes and no ketosis, antibodies negative but responding only to insulin. And 19 years severe gastrointestinal disturbances and underwent all evaluation and nothing was found at. And 21 years he has sensory neural hearing loss. So something is there, but we don't know how to put everything together. So it was all some random presentation, but not to miss out that we are missing out something. But how this was picked up, because he had a sister who developed diabetes and she developed Wolff-Parkinson-White syndrome. And after the examination, she had pigmentary retinopathy, that is retinitis pigmentosa. And from the cardiology, they had sent a genetic testing, and she had this mutation which is very specific for mitochondrial diabetes. So only that actually gave a clue for this presentation, because later on he developed muscle cramps, pre-excitation syndrome, but the ophthalmic examination was normal. So what we wanted to focus was on his genetic testing was actually gave in view of mitochondrial diabetes. So mitochondrial diabetes is very, very rare, but the seriousness of the issue, because patient might have life-threatening arrhythmias and they usually mistake it for type 1 or type 2 diabetes with other cardiac manifestations. And if a patient with a young onset diabetes mellitus has visual disturbances, kindly do a ophthalmic examination to rule out optic atrophy and pigmentary retinopathy. And if the patient has sensory neural hearing loss, in according to that, it is not just a simple type 1 we are dealing with, it is something more than that. And mitochondrial diabetes, the most important thing is pigmentary retinopathy, cardiac disease, conductive hearing loss, short stature. The patient had all these symptoms, but we were not able to put it everything together unless the sister developed serious manifestation and the evaluation was done. And the mother didn't have diabetes. The mother had diabetes, but it was not as severe as this. So now I just want to conclude with this thing. There are even other types of atypical diabetes, that is severe insulin resistance syndromes and lipodystrophy, which actually stand here because the insulin secretion is very normal, but the sensitivity is very, very low. They are like severely insulin resistant. So lipodystrophic syndromes and insulin resistant syndromes also comes under atypical diabetes, and for want of time I am not explaining it them. So these are the spectrum of atypical diabetes: insulin resistant, lipodystrophic, syndromic diabetes, autoimmune, ketosis prone, mitochondrial, monogenic. So we have to classify them into either one of the diabetes because genetic testing is important, laboratory evaluation and precision therapeutics for improving the quality of life and actually putting them in what care they want. And this was a study which was done in our period. So among 700 type 1 diabetes patients, we had almost at least 30 patients with Wolfram syndrome. So I just want to highlight the importance because Wolfram is a severely debilitating disease and they want to be taken care of in all the aspects, and even some had Modi, so that is different. So concluding the talk, so this is very, very important because we can predict the disease progression, and the prognosis and decision making actually is very, very important. If we find out what is the type of atypical diabetes the patient has, instead of just addressing them to have atypical diabetes, treatment optimization and the genetic counseling and counseling of the family members is important because they might be heritable. So with this I conclude the session, and thank you everyone for your patient listening. Thank you.
Thank you, Dr. Nivethitha, for enlightening us on the spectrum of atypical diabetes.
3 months back, in the Journal of APA, they had a presenting a case series where they have described double diabetes. A patient with type 1 who develops features of insulin resistance. And what is your take on this?
So double diabetes is like recently they are incorporating type 1 diabetes mellitus person who in the adulthood, when they become obese, they develop certain characteristics where they cannot be just identified as only a type 1 diabetes. Because of the obesity, they develop severe insulin resistance. So during those times, in addition to insulin, they even require metformin and other some insulin sensitizing. So,
Cases like this?
yes, sir. Like some type 1 diabetes patient, because type 1 diabetes, because of the malnutrition, the other thing, we don't tend a lot of dietary restriction these days, and because of the long-standing insulin intake, it is also a metabolic hormone. Obesity in type 1 diabetes is now becoming a major concern, and that's what they term as double diabetes. That terminology is there.